All right. Well, thank you, everybody. We are running quite far behind. This is going to be my topic here, tailoring thoracolumbar deformity surgical strategies to the frail. A lot of this has been covered in really great detail, really eloquently so far. So I'm going to, for the sake of time, move through this fairly quickly. But I do want to show how some of these concepts really particularly influence me in my minimally invasive spine practice. These are my disclosures, not really relevant to what I'm talking about today. But again, looking at adult spinal deformity surgery for some of the work done by all you guys out in the ISG out there, we know very high complication rates in the 50 to 70% range. But what we also know is, in these complex surgeries, if we give patients through this, there still is in any related outcome measure that you look at, these patients do much better in the long term compared to those that don't have surgery. And so associated high complication rates, but still great improvement with these types of operations. This is some of the work done by Chris Ames and John Burke when he was our fellow. First of all, defining the problem. In these complex surgeries, frail patients and the complications they're experiencing, how do we categorize these types of failures? And we wrote a paper about this that you can reference to talk about PJK, mechanical failures, and those sorts of things. Now, at UCSF, for these frail patients, we do have order sets built into the EMR where you can activate a prehabilitation order set. And so for patients that fall into these categories, there are options if you have the time and the resources to get these patients somewhat more optimized in the preoperative setting before undergoing a deformity operation. Now, I'm going to talk about some of these concepts by way of history. And first is a relatively straightforward case, is a 78-year-old female, overall very healthy. If you calculate her frailty score, she's in the not frail category. She's had multiple years of back pain, some leg pain, and although intact, she does have a fairly complex deformity where she's sagittally imbalanced, coronal shift, type C curve, and decompensated with an elevated pelvic tilt. She's had an onlay fusion in the past, so solidly fused in this deformed alignment, and does have stenosis explaining her leg pain. And again, autofused both anteriorly and posteriorly at the lumbosacral junction. So this was our plan. What would be our standard plan at UCSF, open T10 to pelvis with an asymmetric L4 PSO, multi-rod construct, cement augmentation of the UIV and the UIV plus one, and ligamentoplasty. I'm typically using navigation for all these operations and employing the two-surgeon model. So I do all of these cases with Elecos, and we really do believe in this model. Some of the data behind these techniques, Chris has written about multi-rod constructs and decreases in revisions in PJK to a very highly significant level, and we really have moved towards these multi-rod constructs for all our deformity. Mike talked about this earlier. He's really kind of the leading edge of a lot of this research, ligament augmentation to prevent PJK, PJF. And in several of his papers that I'll reference here, using this particular technique, again, to your talk yesterday, you can get significantly decreased rates of PJK, and this holds true through the long term as well in this minimum 1-year follow-up data set with a large group of patients. Now, cement augmentation, this is alluded to a little bit, particularly Chris's and Vedat's technique of more or less fluoro, less vertebroplasty, so adding efficiency and decreased radiation exposure to the patient and the surgeons. And if you look at this, even on multivariate analysis, looking at PJK and PJF, the vertebroplasty at UIV and UIV plus one really does stand up to that multivariate analysis, independent predictor of PJK and PJF. This has also been alluded to even just right now with Raj, but we do believe in the two-surgeon model. And Chris and Vedat did publish this. Similar radiographic correction with 1 versus 2 surgeons, but significantly lower blood loss, shorter surgical time, and overall less major complications, less return to OR. And so again, we're applying this strategy to all of our deformity patients. This is what this particular patient looked like during surgery. You can see the deformity, and after the instrumentation, decompression, and ultimately the correction, multi-rod construct. You can see the ligament augmentation, and the closure of the PSO. And this is what it looks like intraoperatively. So this is alluded to a little bit yesterday as well for complication avoidance. Intraoperative reconciliation using the O-arm and getting basically a long plate during the operation. You can measure all the things that were really well described yesterday by Mike and others. L4 to S1 lordosis, PILL, and both spinal hip axis measurements as well. These are done at the end of every case and corrected if needed. This is what it looked like, both intraoperative reconciliation, pairing very, very well with what the ultimate construct looked like in the postoperative setting, both sagittally and coronally. Now, this, again, up front, that patient was not frail. Now, Corey gave a really amazing talk this morning on frailty, but just to define it one more time, because it's such an important concept, frailty, it's a medical syndrome with multiple causes and contributors characterized by diminished strength, endurance, and reduced physiologic function that increases an individual's vulnerability for developing increased dependency or death. Basically a measure of physiological reserve and the ability to recover from an insult such as adult spinal deformity surgery. It does increase in prevalence with age. And this is critical because in the general surgical literature, now moving into the spinal surgery literature, it does correlate better. Frailty correlates much, much better than chronological age, the rate of infection, dehiscence, any type of infection, delirium, adverse events, length of stay to what was just discussed, discharge location, and mortality. The frailty index that the ISSG came up with was the first deformity and spine-specific frailty index. The way this was defined is at least 30 to 40 variables. This is how you select a frailty index in any setting. It has to be related to health status. The prevalence increases with age and doesn't saturate early. And it does cover a wide range of systems, in this case, systems that are specifically important to us as spine surgeons. And this is what it looked like. I borrowed this slide from Chris. I don't know what poor pre-med student had to design this for him. But ultimately, this was how the 30 to 40, or the 40 adult spinal deformity frailty index categories were defined as the overlap of multiple pre-existing frailty indices and figuring out which one of those were specifically relevant for spine surgery. And as Corey mentioned, this was published in Neurosurgery Focus, and frailty, particularly when codifying it into different severities of frailty, does predict complications. And the importance, and this will ultimately get into how we're tailoring these strategies to the frail patients, but a frailty index does really need to be paired with an invasiveness score if you're looking to predict outcomes based upon frailty. And so the ISSG also worked on an invasiveness score based on their data set. And ultimately, when figuring out if the invasive score works or not, it has to be correlated with things that you would think of with invasiveness of surgery being increased blood loss, increased length of surgery, and then comparing that to some existing invasiveness scores like MIRSA. It did actually really pan out extremely well as far as being able to describe the surgical invasiveness of our operations. So in thinking of that with the background and under the mentorship of Chris, I was really interested in how this applied to minimally invasive spine surgery. And so we worked on this paper, again, John Burke, when he was our fellow, comparing open and MIS TLIF patients in both the frail and the non-frail categories. And what we found when looking at different outcome measures, the two that really panned out were discharge location other than home and revision surgery at 2 years. And what we found is that frail patients, if they underwent an open TLIF, they had the frail patients did significantly worse in these two metrics compared to the non-frail patients. But if these patients were treated minimally invasively, it kind of leveled the playing field. So frail patient did just as well after this as, they did the same after minimally invasive TLIF with irregardless of whether they're frail or not, indicating that that may be an important application of minimally invasive spine surgery, particularly when treating frail patients. And so thinking about ways to apply this to the spinal deformity population was, to me, the next thing that made sense. And I love that we have Martin coming up to talk next, and we had a great talk by Coy yesterday about this. But just how we think about this in this, again, a case here, an 82-year-old male, multiple medical problems. He falls into the severely frail category. He has severe mechanical back pain, normal exam, and he does have both sagittal imbalance as well as coronal deformity. Multiple levels of stenosis contributing to his leg pain. And this is ultimately how we came up with our plan. So trying to apply as many of those principles that I discussed early from open surgery to a minimally invasive surgical strategy. Again, 2 surgeon models. So Alekos and I discuss all these cases, and we do them together. Started with a stage 1 L2 to S1 OLIF. At L5-S1, a patient-specific ALIF cage, left lateral approach with a vascular surgeon using navigation. And then as a planned second stage, I'll show you some of the imaging. I get the thin cut CT in between stages, which helps with robotic pre-planning and custom rod designs. T10 to pelvis, minimally invasive fusion with some minimally invasive tubular decompressions to treat the radiculopathy, robotic screw planning and placement, patient-specific rods, and this is done through a midline incision, muscle-sparing screw and rod placement. I was lucky enough about a year and a half ago to spend some time in San Diego with Martin and learn that technique that's been really beneficial for me. Some benefits to doing in frail and obese patients and operating on them in the lateral position. You can see the abdominal contents migrate forward. This is a technique for the L5-S1 lateral ALIF in the lateral position. Incision planning anterior to the ASIS. And in planning your incision between this triangle that's described by these vertical lines. Ultimately, this does have some benefits. It's muscle splitting, possible less hernia, possible less pseudo hernia, wide exposure to the disc space with less peritoneal retraction, so perhaps minimizing ileus. And this is what the 5-1 custom implant looks like. So being able to take into consideration end plate anatomy, particularly in patients that may have bone density issues, as well as being able to target both foraminal height reconstruction and lordotic targets. And to some of the questions that have come earlier, there has been some research that's been done based on this. Chris has been involved in a lot of this. But looking at ability to treat successfully your target focal lordosis using patient-specific implants, whether it's ALIF, lateral, or TLIF, and this can be done with very, very high reproducibility. And this can be also translated more globally, looking at realigning and improving upon spinopelvic mismatch using patient-specific interbodies that can help you achieve these goals. And this is the third paper that was published upon this from the same group. This is what it looks like with that reconstruction. We've seen cases like this before. I do think it's important to get this CT scan in between. It helps with robot registration and planning. It does streamline that second stage and getting standing x-rays to see how close you've come. With custom rods, we can plan our corrections, we can plan our screws using robotics and that preoperative CT scan to facilitate correction and rod placement. And this can all be done before the surgery starts. This was kind of hot off the press, but we've looked at our series of patient-specific rods. Similar theme here when we looked at our series at UCSF. There was a significant decrease in rod-related mechanical complications when we use these custom rods. This is what it looks like. I'm working with Tony Makula, my past fellow from Mayo Clinic, and then doing the components of the case with Elecos, as you can see there. And similar concepts, intraoperative reconciliation, making sure that we hit our targets. And, potentially, these are costly surgeries, but we may be getting some cost savings on the back end. No ICU stay for this patient, no blood transfusions, went to rehab post-op day 7. And by 6 weeks, it's off all narcotics and is feeling better. So these are how I'm thinking about frail patients. I am going to rely or try to, if I can, use some form of minimally invasive technique for these based on some of our work on frailty. Thank you very much. All right, I think, guys, let's get some coffee and, we'll, just in the sake of time, we'll go straight into cases. And then we'll get done in time for lunch.